So welcome to Circle Symposium. Appreciate you all joining us on an early Friday morning. My name is Chao Wei. I'm the Chief Technology Officer at Circle. And up here with me, we have an excellent panel of speakers this morning. We have Dr. Fantanis, Dr. Steele, and Dr. Almeida. So the theme for SCCT this year is Be Where the Future Is. At Circle, we believe the future for managing coronary artery disease includes automated plaque analysis and quantification. And this is what we center our talks on this morning. We want to talk about the clinical utility of plaque, give you a few case examples, and then discuss where the future is going. But before I hand the mic to our speakers, I want to give you a little bit of background about Circle. So Circle was founded in 2007. I had the fortune to join the company at an earlier stage. It was much smaller, and what struck me at the time was this company with a lot of deep clinical expertise and also an ambition to build a broad, accessible cardiovascular imaging platform. And that was how we built the company. Today, we're in over 90 countries. We're in each of the top 10 hospitals ranked by Newsweek globally. And then we're also in the top 25 hospitals ranked by Newsweek in the US. So many of you will know us from our cardiac MR products, but we have also been in the CT game for nearly a decade. So in 2015, we worked with Dr. Leipzig out of Symposium on our first TAVI solution. Today, we have a much broader product portfolio. We have a full suite of cardiac MR tools. We also have a full suite of cardiac CT tools that rivals our MR. We have a full interventional planning portfolio, including TAVI, TIMVR, and left atrial appendage closure, and then we have EP and acute stroke. Our focus at Circle has always been building a comprehensive cardiovascular imaging solution, a one-stop shop for all cardiologists and radiologists so that you don't have to use multiple solutions in your daily clinical routine. We have also been an early adopter of AI at Circle. Our journey started in 2016. Today we have 32 deep learning models in our software. We don't believe in building black boxes. We like to build AI that puts the user in control, which means that you can interact with our software in real time and the AI results. Our models are often optimized for speed so that you don't have to upload them to the cloud and then wait for the results to come back. Now, our core CT platform was built from ground up for advanced CT analysis. We designed the platform with AI at its center, with all the processing done on the server side before you open up the study. All of our modules come with integrated reporting, and this includes your typical stenosis assessment, calcium scoring, CT function, as well as a new AI-based plaque analysis. And this list of functionalities will continue to grow and expand as we further build out our platform. So this is our CT function module, which we released last year. This was the first FDA-cleared CT function product on the market with a QIH code, which means full AI-based analysis. Our automated analysis offers expert-level performance, which means our segmentation accuracies are well within inter-reader variabilities. So the segmentation produced by our AI is no different than having another human expert. And of course, all the processing is done on the server side with all your results, values, volumes, measurements, all pre-populated into the report when you open up the study. Now for complex anatomy, such as congenital cases, you also have full control over the segmentation. This is our latest TAVI module with full AI automation. And what you see here is what typically takes 10 to 15 minutes of analysis, navigating to your aortic root, finding the annulus plane, measuring your ostia height, sinus-tubular junction, all of which now takes a matter of 1 to 2 seconds with an optimized AI model. And you see it working in real time here. It automatically generates 14 measurements with an accuracy of 1 to 2 millimeters, with a very fast inference of 1 to 2 seconds per phase. We also have a state-of-the-art coronary analysis module with the latest AI-based vessel tracking technology. Our detection rates are in the high 80s to 90%, and these numbers will continue to go up as we further improve our models. This is an active area of investment and focus at Circle. We have seen many cases where traditional software, such as vendor solutions, they will fail in vessels with significant or total occlusions. Our AI-based vessel tracking technology, which takes a global view of the entire vessel tree, is designed to overcome these difficult cases and accurately extract the center lines here. And then lastly, I'd like to introduce our new AI-based plaque analysis. So this will be the first fully automated on-premise plaque solution available on the market, meaning that you no longer have to decide which studies you want to send out, upload them to the cloud, and then wait for the results to come back. All your CTAs with coronaries can now be automatically processed on the server side with plaque quantification results immediately available when you open up the study. And here you see an example of our report that's generated by our software. Now, to validate our solution, we compared the plaque volumes produced by our AI to 3 expert readers at the Mayo Clinic, and we saw very high correlations of 91% and 86% for total plaque and non-calcified plaque volumes. The volume differences are within 10 to 15%, which is well within inter-reader variabilities. Of course, in addition to just having accurate and reproducible values, we also offer full user control. So here we have virtually reconstructed the entire vessel tree in 3D with both inner and outer boundaries. So you can interact with our vessel segmentation as well as the plaque quantifications real time with our software. So this is shown on the left-hand side here, and on the right-hand side here, we have an example of our structure report with calcified, non-calcified, and low attenuation plaque quantifications. So the CE mark version of the software is available today. The FDA version will be coming over the next several months. So now that you have seen our latest plaque tool, I'd like to turn the mic to our first speaker. I'd like to welcome Dr. Emilios Fantanis. Dr. Fantanis is a staff cardiologist out of ProScan Imaging North Naples, and he's going to talk about the clinical utility of plaque and why having an automated software like Circle CVI is important in daily clinical routine.
Thank you. Good morning. It's early, but we're all here. So I'm going to go over the recent SCCT expert consensus document on imaging plaque. And in 2021, this document came out and really kind of emphasized the paradigm shift that we're all starting to see, how we're moving away from coronary artery stenosis guiding care and treatment options into more plaque impact and quantification of plaque into our reports, and more importantly, the importance of this plaque. We know from studies that nearly 1 in 3 patients referred for coronary CT will have non-obstructive coronary artery disease, and it's important for us to know that, as these patients are identified to have this disease, that their annualized events rate is significantly higher as compared to those who don't have any coronary artery disease. It's important for us to be able to identify and know the management for these patients. We also know from studies that intravascular ultrasound has identified high-risk plaque features often related to acute coronary syndrome and stable plaque, and we can see a majority of these findings with cardiac CT that have excellent correlation, and the statement emphasized the importance of identifying these plaques when we see them, whether it's positive remodeling or spotty calcification, to some of the more challenging findings such as the napkin ring sign or low attenuation plaque. It's important for us to ensure that if we identify 2 of these features, that we mark it as a high-risk plaque feature on our report to ensure that patients and their referring physicians are aware of what that means. But we know that a lot of these high-risk plaque features are not as uncommon as we used to think. They can be seen in 15 to 34% of patients who present with stable chest pain, and more importantly, their predictive value is strongest in younger patients, women, and of course the patients who don't have obstructive coronary artery disease. But it's important to note that high-risk plaque features is just one of the many risk markers that provide additional risk stratification to guide some of our care. More importantly, as quantitative measurement of atherosclerotic plaque has become more widely available, we know that it is possible to do. And more importantly, this has been compared to IVUS as a gold standard. We've noticed that from meta-analysis in the early 2010s that there's a pretty good correlation between what we're seeing on intravascular ultrasound and what we're seeing in cardiac CT, with a difference in plaque volume on average of about 1.5 milliliters or millimeters, and area under the curve for correlation to be quite high. So it's important for us to know that what we're seeing is what our colleagues in the cath lab are also seeing. More importantly, we asked the question, so we can do this quantitative plaque assessment, but what does it mean for our patients in terms of cardiovascular events? Well, this is data from the Scott Hart, and we found that the percent of plaque to vessel volume became the single greatest predictor of incident MI. when they quantified low attenuation plaque burden greater than 4%. This was associated with a nearly five-fold increase in the hazard ratio for an MI. In particularly in patients with non-obstructive coronary artery disease, it was significantly predictive of incident MI. And it is important for us to realize that it's more than just the high-risk plaque features, but the volume. So then in 2024, a new document came out and said, now that we all have the possibility of quantification, AI is starting to enter the field, what are the things that we need to be aware of and what are the things that we need to work on? So more importantly, we get back to the basics. So how exactly should plaque be quantified? You have to use a semi-automated software with a manual oversight for vessel lumen and boundaries. And this is important for us to understand that the goal is to really focus on vessels of greater than 2 millimeters in diameter due to the resolution of CT. As I'm sure you will all explore and find out, there are new technologies evolving that are challenging and pushing the resolutions of cardiac CT. So it'll be important to see how that's going to affect our understanding of plaque quantification. But more importantly, what they really emphasize is that if you're going to be using this, you need to use validated tools that have excellent reproducibility with good results. But it's also important to remember the basics. You need to have high quality images. You can't possibly engage in plaque quantification or understanding of consistency if you don't have high quality images. You need thin slices, less than 1 millimeters. You need to ensure that your matrix size is at a minimum of 512 by 512 in dimensions and a small field of view. You also need to ensure that you have high spatial and temporal resolution, and more importantly, consistency in your contrast enhancement, because remember, your tube voltage, your iodine concentrations, all those are really going to affect the type of plaque that you're going to see, and more importantly, what you're seeing. Another concept that they introduced that you really need to have, and they did a really good job in that document, is emphasizing plaque metrics to know. Oftentimes, you'll get different reports for different vendors. You'll read different papers and how they're trying to explain plaque. And I think overall the consensus was that we need to know what total plaque volume is. We need to know what the percentage of that plaque volume is and how that's calculated. And more importantly, remodeling indexes that are often referenced. But more importantly, it's important to know that what's being defined as plaque, it's the volume between the inner lumen and the outer vessel boundary, and how that is derived from not just the disease segment, but also a cross-sectional analysis to derive that volumetric analysis. So it's not just looking at it on the short axis or the long axis. More importantly, they said there's a lot of vendors. They provide at least 7 different vendors available at that time of the publication that have software available for you to quantify plaque. But understand that there's no universal Hounsfield unit threshold, and attenuation is going to vary by scan settings. You need to understand that cross-platform variability remains high. So if you're going to be doing serial studies in patients, you at least need to try to attempt to ensure that the same software is utilized with each patient as you're doing serial evaluation. Now, obviously, a lot of this is coming down to questions about reimbursement. And right now, CMS, for those in the United States, has a local LCD for determining who's eligible. As of today, patients who are eligible to have plaque quantification reimbursement have to either have stable or acute chest pain. They have to have no history of known coronary disease. And the more important thing is in the intermediate risk category. The disease cannot be above that 70% stenosis. It has to be in the 1 to 3%, in the CAD-RADS 1 to 3 category, or they have to have a negative or inconclusive ACS evaluation. What's not covered, and this is really important, as there's going to be a lot of discussions about primary prevention in asymptomatic patients. This is not utilized for screening. You cannot have a normal coronary CT and then send it for plaque quantification once you reported it, and then want to have this, help me determine if I missed plaque. You have to make the diagnosis before you'll get reimbursed. More importantly, high-grade stenosis. And this means like a distal vessel or a branch vessel with a 70% stenosis might be the determining factor that if you call the CAD-RADS 4, they're not going to cover. Anybody within less than 30 days post-MI or anybody for surveillance purposes, it's also not covered. These are the CPT codes that you have to use right now and that are reimbursed by the different companies that provide coverage for your Medicare patients. And it's important that when you are documenting this and you're going to send it for reimbursement, Medicare will not cover if it's not FDA-cleared AI software. And this is very, very important. You have to complete the CT first and interpret it. And then more importantly, they really are emphasizing they want a CAD-RADS 2.0 based interpretation in order for them to determine the eligibility of the patient. So if you're not doing a lot of CAT RADs, you might run into that. So what do we learn from these two consensus statement papers? And really the important thing is you have both a clinical from the initial paperwork, we're going over all the data, and more importantly, the technical blueprint, which is really important now in 2025. We're really starting to shift into a model where stenosis remains important. It's an important part of our story, but really plaque all along has been the main character, and we're really starting to get more focused in what does it mean, how do we determine, more importantly, really, how are we defining it? These quantitative metrics are potentially going to guide the therapeutic intensity and follow-up strategy for a lot of our patients, but adoption is going to depend on a few things. One, you got to learn how to do it, and you have to be trained in how to do it correctly. More importantly, artificial intelligence is part of it, so we have to know how to integrate these AI outputs into not just the interpretation, but our reporting workflow, and then clinical trials. We have to understand and know what truth is. If patient outcomes, more than just a surrogate endpoint, we need to understand if what we are seeing, how we are treating it, is it going to make a difference in what it does to our patient outcomes? And more importantly, reimbursement, right? Whether it's in the United States or outside the United States, time consuming this, interpretation of the reports, it's all important part of the thing. So make sure that all of these things are remembered, and let me know if you have any other questions or concerns.
Thank you, Emilio. We'll leave all the questions till the end after all the presentations. So now that you have seen the recommendations and the guidelines, we want to give you a few case examples. And here I'd like to introduce our second speaker, Dr. Shone Almeida. Dr. Almeida is the Director of Cardiac CT Program and Director of Cardiometabolic Diseases at University of South Florida. And he's going to give us some case examples on how actually plaque is used in patients.
Good morning. Yes, it is early. So, I run our cardiometabolic program at USF, and I find plaque analysis to be immensely helpful. And I sometimes will do stuff that's not quite guideline indicated. But let me share with you some case examples that really highlight where I think plaque plays a key role in patient management. And hopefully we say some controversial things here, and that'll drive some discussion in the Q&A session. So, case one. This is a 54-year-old woman. She has a history of hypertension, hyperlipidemia, probably breast cancer diagnosis for which she was treated with radiation. You can see her lipid profile as follows: an LDL of 101. She's been on a low-dose or moderate-intensity statin with a rosuvastatin 20 milligrams. And this is her CT scan. So she went to get further risk stratified with a calcium score, came up with a score of 0. Now, if you look at all of our guidelines and data, most of you would say, well, score of 0, this is someone you wouldn't necessarily treat. And yet, she has risk factors that are really hard to quantify when you look at things like ASCVD, right? How do you quantify the effect that prior chest radiation has had? So she went on to have a coronary CTA, which in the LAD, as you can see on the initial panel, shows some soft plaque. There's a lot of lumpy, bumpy stuff that you see in that vessel. And when you drill down with Circle software and use the AI tool to really identify what is that plaque volume, you can really now start to quantify that she, in fact, has very early onset disease. And the calcium score is really going to underestimate her risk. So in this case, she has a total plaque burden of 21 cubic millimeters, putting her in a stage 1 heart disease category. And what we did with that information, we said, well, wait a minute, maybe we're not adequately managing her lipids. Maybe the LDL of 101 isn't enough. How can we start to get a little bit more aggressive? So I think, the plaque-based screening strategy or plaque-based strategy really is helpful for those cases where you need very clear risk refinement in patients in whom a calcium score or coronary CTA by itself without this added AI tool may not be sufficient. And the problem with this, with our current model of heart disease, is that we focus so much on stenosis. We're waiting for people to have symptoms, when in fact, the majority of those MIs are occurring in those 30 and 20% lesions. And you're never going to find those patients coming into your office with chest pain or shortness of breath. And as a result, we see or learn from the Young MI Registry, and I think you'll see this same slide shown in many other talks today, but we undertreat patients. In the Young MI Registry, these were adults under age 50 who went on to have a heart attack, and they went back and said, well, how many of those patients would have actually been recommended for statins? And actually over 52% would not have been recommended because by ASCVD risk scores, they fell under that statin threshold. So we need something better. Relying simply on population risk scores isn't going to help us move the needle on heart disease prevalence. The second case, so this one's interesting. So this was a 56-year-old male. He has a renal disease, hypertension. He's a smoker, a former smoker rather. No really strong family history. He's never really been on a statin. His cholesterol profile, as you can see here, with an LDL of 138, A1C maybe in that pre-diabetic range, total cholesterol of 204. How do you manage him? How do you further risk stratify him? So, of course, the first step is to get a coronary calcium score, and sure enough, he has a total score of 13.3, which puts him in that 52nd percentile by MESA. Now, a lot of you might say, well, that's enough, right? I know enough information at this point. This gentleman has heart disease, demonstrated by a calcium score. He warrants lipid-lowering therapy. And if we take a step further and we say, well, wait a minute, what's below the surface, right? It's that iceberg analogy. The calcium score is allowing us to look at the very tip of the iceberg, allowing us to scan the surface of the ocean, giving us some warning that there's something there, but doesn't allow us to look below the surface. And if you look below the surface, he actually has a fair amount of soft plaque. In fact, I have patients like this where when we do these scans, we find a high proportion of low attenuation plaque. And as you just heard, that's a 5-fold risk increase, right, over the next 5 years. So how do we really start to use these technologies and use AI to further and personalize risk refinement? In this gentleman, the calcium score maybe wasn't completely sufficient to do that. And morphology really does matter, right? Whether you have hard calcium plaque, low attenuation plaque, soft plaque, morphology matters. So this is data from ICONIC showing us some plaque is actually maybe on the more protective side, if you will, like less likely to rupture. So high dense calcification, more protective. On the other hand, those really soft necrotic core plaques, fibrofatty, the low attenuation plaque that we see on CT, are more pathologic. So where do you fall in that spectrum? And if you look at how plaque can help from a prognosis standpoint, in fact, high-risk plaque features, even by itself, even the absence of severe stenosis, already has incremental prognostic determination for those who go on to have an MI. And certainly if you combine that with severe stenosis, now you end up with that worst-case scenario, which is the red line on the bottom. And this was mentioned already, so this is a Scott Hart data basically showing that if you have more than 4% burden of that low attenuation plaque, you have almost a 5-fold risk increase. So there's data here, and we'll find out from some of the prospective trials and registries that are ongoing, and we'll hear about it, I'm sure, today, some early data. How is this really going to affect care? And that's the key part, right? We want to see, does this reduce MACE? The third case is maybe a little bit controversial, so I'm hopeful for some questions at the end. 53-year-old gentleman, he's a former smoker, hypertension. He's been on a low-dose statin for years now. I think he was something like 18 years. He had no known coronary disease history, but he was having some chest pain, anginal symptoms. LDL of 99, lipoprotein A was a little bit elevated at 127 nanomoles per liter. So he had his initial scan. This was actually done in 2021 when he had some symptoms back then. This is someone I followed. His initial scan showed some calcified plaque, soft plaque, as you can see in this initial territory. And by plaque analysis, clearly has almost a moderate stage 2 heart disease, right? With a total plaque burden of 211. His low attenuation plaque maybe isn't quite getting as high as you might think, but a fair amount of soft plaque. I then followed him for some time. He had a second scan 4 years later, April 2025. And you can see his plaque burden, despite treatment, has progressed. So how can we use plaque to really follow treatment efficacy? No longer just simply relying on surrogate markers like an LDL to say, well, we've hit our goal, we've hit our threshold of under 70, let's leave you alone for the next 20 years. But instead, where can we use something like a look-back CTA? And I'm not advocating doing this every year, but a look-back CTA to understand what's the effect of your treatment. How have you changed his overall plaque burden, number one, and how have you changed that overall plaque phenotype? Because if you haven't changed the phenotype to increase your calcified plaque burden more than your non-calcified plaque, then perhaps you need to augment your therapies. And that's what happened in this case. And we know that these medications actually change treatment. So in this case, he went from 211 in 21 to 325, putting him in a severe stage 3 category. And certainly at that point, some thoughts might be to definitely augment his therapies, perhaps now in high-intensity statin plus a PCSK9 and aspirin for an antiplatelet strategy. blood pressure control as well. And if you're diabetic, hey, is this an opportunity to put you on a GLP? And showing someone this plaque progression data really helps them adhere to the treatment recommendations you're making, helps them make those lifestyle changes because they clearly see it doesn't take a cardiac CT reader to tell you there's more plaque on that follow-up scan in 25 than there was in 2021. We know that these medications impact plaque morphology. In fact, that's the greatest effect they have, right? There's some reduction in overall plaque burden, but really it's plaque transformation. And that's what we want from your statins, from the PCSK9 inhibitors. And so we want to be able to look at these things to understand what are the effect of our therapies. I think our field really has come into a very different realm. And last year at ASM and this year as well, this to me, I think, is really the future of preventive medicine and cardiovascular disease management. We've gone from looking at a cardiac CT image, we've identified these high-risk plaque features, but no one really knew what they meant. There's a lot of variability between readers and how you define it. Low attenuation of plaques, body calcification, napkin ring sign, positive modeling, all of which correspond to these thin cap fibroatheromas on IVUS and OCC studies. And sure enough, that allowed us to identify vulnerable plaques, and they showed up in CADRADS 2.0. But now with these AI tools, you can take it a step further, right? You can start to integrate the plaque into your decision-making using all the patient-level factors that you already do, but now having this additional set of AI data to further refine risk. So now you're moving away from simply a vulnerable plaque to identifying the vulnerable patient. And I think there's future things on the horizon. So where does something like fat attenuation come in? Where does shear stress come in? And I think we'll see more of those tools as we have our better and better technologies. So with that, I'll stop. I'll hand it over and look forward to more questions at the end.
Thank you, Shu. Thank you for all those interesting cases, particular case number 3. So now that we have gone through a few real-world cases, it'd be interesting to see what all this means for future patient care and where the future is going. So with that, I'd like to introduce Dr. Kevin Steele. Dr. Kevin Steele is our Chief Medical Officer at Circle, and he's the Director of Advanced Cardiac Imaging at Peace Health. And he's going to talk about the future of plaque analysis.
Great. Thank you, Chow, and thank you everyone for showing up this morning. I'm going to discuss some about the future of plaque and where it's going. I'd say I'm a slow adopter to new technologies, skeptical of new technologies, and when new medicines come on the market, very skeptical about even some of the data that comes around. And so I thought this was an appropriate talk for me to put together because I learned a lot as I was putting these slides together. So we'll talk about who really benefits from plaque analysis, the role of precision medicine in plaque analysis, and is it really ready for prime time? And prime time, what does that mean? Well, prime time, in my in my opinion, is this ready for primary care? Is this ready for screening, mass population, and such? And then we'll talk about some of the other features of Circle Plaque. And so I like to start with this cartoon, giving this idea of this is really where we are at with the concept of plaque. And everyone in this room knows that this is a fallacy, that plaque is not a binary concept, but this is what our patients think. Either I have plaque or I don't. And if I have plaque, that's a big deal. But we know that it's more finite than that. And even for most of the medical providers, besides probably cardiologists and some radiologists that read CT, that's also the concept that plaque, you either have it or you don't, because I'm going to give you a statin or I'm not. And so why do I need to know more about plaque? When you think about, again, primary care providers, nurse practitioners, physician assistants that are really on the front line, seeing a mass amount of patients per day, that this is what they're thinking is, what can I give this patient to get out of the office? And we know that plaque is much more complicated than just is it binary or not. So this slide, I think, really expresses it well. This is a review paper that Jack Bell and his team has recently published in JCCT, and I think it's a great paper, a great overview of where we are with plaque today for you to look up and read later. So this is a slide that just demonstrates some of the associations of bad outcomes that are related to plaque, depending on the type of plaque that you have, whether it's calcified plaque or non-calcified or low attenuation, and you've heard a lot about that already this morning. The one thing I'd like to point out on this slide is if you look at the hazard ratio of calcified plaques, that's a more narrow curve or a more narrow range that's there. And there is a hazard related to calcified plaque. We've known that for a long time, but definitely not as significant as when you get to the low attenuation plaque or the non-calcified plaque. And so trying to bring this message to your patients or to the primary care providers is very important to try to differentiate this binary concept. When you actually get into the details, it gets much more complicated than that. So who really benefits from plaque analysis? So I tried to break this down into, I think, the three major players that we have that are in medicine today, and the patient being the primary focus of what we are all here and what we're all trying to do is improve our patient's quality of life. And so for the patient, just having that knowledge that they have plaque, what kind of plaque burden they have, that can be quite motivating to them to be more focused on their own health and try to improve their own health. You can have a much more customized treatment plan with your patient instead of just giving them a drug to get them out of the door. You can really sit down with them and go over things such as diet and exercise and other various types of medical treatments. I put there this term MACE in question mark. Our patients don't know what that is. You know, major adverse cardiovascular outcomes and or events, and sometimes I think even between providers, it's a little bit, what does this mean exactly? And so our patients really just want to know, are they going to die or not, or are they going to have a heart attack or not, and to keep that quite simple. So what else is available to our patients? Kind of what are they looking at, and what are some of the other competing factors that go into this discussion with MACE and with plaque and things like that? Well, I put podcasts at the very top. That's a very popular thing, at least with my patients. Get a lot of their information from non-physicians that are trying to be scientific, and some of them do a good job. Sometimes they don't do a good job. But I think this has really replaced a lot of Dr. Google. And so patients will come in already preloaded with this concept of what they think that they need to reduce their cardiovascular outcomes. There's other screening services that have been available for a long time, right? We have screening services that could go to churches and to parking lots at Walmart that will do ultrasounds of your carotids. They'll do ultrasounds of your aorta looking for peripheral arterial disease, and they can identify plaque as well. And so they'll come into the office with this data and they say, well, why do I need plaque analysis if I already know I have this plaque in my carotid? I have the calcium score, and the prior speakers already alluded to some of the issues with calcium score, and that doesn't necessarily tell the whole story, but it is a very much cheaper test to do. It's about $100 where I'm at near Seattle, and much cheaper to do, and sometimes that's what it comes down to, is what can the patient afford. I think that's interesting now. There's a big movement about lab work and blood work that is marketed directly to patients. Advanced blood works, advanced lipid profiles, even some genetic tests that they can just pay $200 or $300 online. They can get their own labs, and they can make their own assessment and their own risk assessment based off of that as well. And those online labs then lead to remote consultation, and I think that's another portion of that too. So these are some competing factors when you're looking at what else are your patients doing, especially those that are very engaged with their health, and so they can come in preloaded with a lot of these questions. From the provider, how does the provider benefit from plaque analysis? Again, it's education. It's educating that provider. The primary care provider is the one that I'm alluding to here, not necessarily the cardiologist that reads CTs all day long. And it makes them smarter, makes them more confident when they're treating their patients as well. Plaque analysis, just like calcium scores, is a motivator for increasing referrals. If you happen to be the center that is doing that, it is providing that service. If increasing referrals increases your business, it increases your revenue. But you can tailor care to your patient, and you know really what's going on with your patient. The idea of serial scans, I think that's a very interesting concept where you make a change and you can go back and recheck and see what is going on with the plaque. And the third portion within healthcare are the payers. You know, at least in the United States, that's a big driver in how us as physicians and how we behave, and sometimes how we practice. Unfortunately, that's just how things go. And so what are they interested in is, does plaque analysis reduce outcomes? And really, does it reduce the amount of money that they have to pay out later on? Is there really value in that for them? So does it really save money or not for them? So if it doesn't, you don't have a payer that's willing to pay for that, that's kind of where this idea of precision or boutique medicine has come in, where you have patients that have enough money to sit down with a cardiologist, get different types of scans done, and so they can shell out that money for that, but that really excludes a huge portion of the population that cannot afford to do so. And so that's I think where this idea more of precision medicine is a better concept than just boutique medicine when it comes to things such as plaque analysis, where you can really get in and fingerprint the coronary artery. And this is images that were taken from Freeman's article. I took it directly out of just showing a particular coronary artery vessel with about a 5-year difference in time frame. So there is a coronary without any calcified plaque on it. About 5 years later, now you see some calcified plaque, and those are just short axis slices of those too. They show that by doing these serial scans that you can identify these patients that are not necessarily responding to treatment. In this paper, they also bring up this concept of staging, which was also brought up earlier. And so we stage a lot of different things in medicine, kidney disease, heart failure, and cancer. And by staging things, that really frames this complex idea of plaques, and also can help dictate treatment and when would you change treatment. And so then you can almost make this more of a cookbook style type of medicine when you identify these plaques. There's a lot of data that comes out in these plaque reports, and so try to make this simple for that primary care provider. So these are the ideas of staging. So you can stage by stenosis, and so that's what this first column is showing. Very straightforward and simple, but also by total plaque volume or a percent atheroma volume. And to stage this stage your coronary atherosclerosis, stage 1 and stage 2 or stage 3. And so these are some of the potential treatments that are out there for managing coronary disease just in general. But and they summarize in this paper how these can impact low attenuation plaque or perhaps calcified plaque. So statins, of course, we know that has made an impact as far as plaque and plaque quality. The next one would be the fish oil like Valsepa, right? Prescription strength fish oil. And then you have your PCSK9 inhibitors. Colchicine, I think, is a very interesting concept. Colchicine is coming around. It's been a drug we've had for a long time, very, very cheap. There was just a paper just a few days ago that was published in Nature using low-dose colchicine for 12 months on a daily basis and had reduced cardiovascular outcomes. And I think that dovetails nicely into what we're saying here, where colchicine was shown to reduce some of that lower density non-calcified plaque as well for that. And then the last one, don't forget about diet and exercise. That's really critical. It's very challenging, diet and exercise, to convince some patients to do that. But there definitely is an impact with diet and exercise. It's not just something to get them to occupy their time. So if you take, you put these together, you have your stage, you have your treatment plan out there. And so then this can help kind of, again, like do a little cookbook style with all this plaque data that you have. What do you do with it? How would you treat that? And this is just a concept that was proposed in this paper. And I think that there's a lot more work that needs to be done when it comes to how these medications impact outcomes, how they impact plaque. But I think this was just a very interesting concept that I thought that I wanted to share with you today. And I just want to, again, plug diet and exercise. Another nice piece of data that came out of the Scott Hart sub-study looking at the impact of the knowledge that you have atheroma, or that you don't, or that knowledge you don't have that when it comes to diet and exercise, and the impact that it can have. So these little blue blobs that you see on the left side of this are that's demonstrating just risk assessment the traditional way with the cardiovascular risk score in patients that did not receive any imaging, and that change that it had in their cholesterol when you try to prescribe diet and exercise. But just adding that knowledge with those images, orange image on the far right, having that knowledge that you have plaque made a much more significant difference in lowering LDL cholesterol, which should translate into outcomes, right? Should translate into lower heart attack, lower strokes, and hospitalizations for that. So it really does improve compliance, and I think that we've shown this years ago with calcium score, that just the knowledge of having plaque makes a big difference. But again, also knowing that you have various types of plaque in there, I think that's a bigger driver home to the patients delivering that message. So is plaque analysis ready for prime time? Well, I think, again, these things, all these circles would have to, I think, align, in my opinion, for this to be ready for prime time, for at least for primary care to reach out for that, or perhaps even just spreading out to just regular cardiology clinics. So we definitely have the imaging technology. That's why we all are here already. We're talking about this, and we have a professional society support. We have the SECT consensus paper on that. We have industry support through third-party software like Circle for the post-processing of plaque analysis as well. Insurance, that's a little bit up in the air. I have a lot of challenges with insurance, just trying to get a regular cardiac CT, and a much more higher challenge trying to get just a calcium score out of insurance. And so I think there's definitely some work to be done there. There's a reimbursement and for getting plaque analysis performed, but not everybody is on board regarding the players. And I think on the science side, when it comes to what do we do with that data, I did go over some of the different treatments you can use for various types of plaque, but there's not really a big body of data to support that yet. There's a lot, I think we can all connect the dots and logically think that this treatment's going to impact this, and it does make sense, but it really needs to be under scientific scrutiny for that. So we've all have seen this at least in medical school, but the idea is this a screening test? Is plaque analysis ready for that as well? So it's another way to try to judge if this is ready for prime time. Looking at the accuracy, if you think about tests such as mammograms or PSAs or colonoscopies that we use to screen mass populations for disease, think about that in terms of plaque analysis and the accuracy and the reproducibility that we have with that. The availability, is that test available? The practicality of it, and is it cost effective? I think that's one that is still, I think, yet to be seen. Is it worth it? And if it's cost effective, then that's where you'll see, I think, more insurance companies come on board. And then also, are we treating a disease-related condition? So coronary artery disease is a very common finding, at least in the United States. And so it's definitely, there are features here where plaque analysis can fall into that paradigm of becoming a screening test. I would say that cost of it is part of that challenge. So specifically with the Circle and our plaque analysis tool, I think I just want to kind of highlight some of the points that I feel as a clinician that I think that are of value. And so when you're assessing other types of software, you're looking at other types of plaque analysis tools, I think these are some things that would be important to consider when comparing one product to the next for that. And the big one for me is really the send out versus keep in house. And so there are, I have patients that don't want their data sent out. And sometimes you send out, if you send out something, the patients don't even know that you're sending out their data. And so I have some patients that are very protective about putting their personal data into the cloud, where with a Circle's product, everything is kept in-house. Nothing leaves the hospital walls when you're doing an analysis or anything for that. And also there are certain institutions where you're not allowed to send data out. For example, when I was member of the Department of Defense, you could not do that. You couldn't send out data from soldiers and airmen up into the cloud for someone else to process. And so that was a challenge. And then even looking even broader than that, there are countries that have policies where you cannot send data out away into the cloud as well. And so they can be quite limited in some of these other external services that can provide some data for them. So the idea of keeping this product in-house is a very powerful one when it comes to that and protecting patient privacy and protecting patient data. The other part about keeping it in the house is that you can see the images that are done. You can evaluate the accuracy of the plaque analysis. You can modify it. So it's not really a black box of just here's some data that you get. You can actually see what's going on, and you can feel more confident that this data is correct. And the third part I just want to harp about keeping it in-house that I think is important is the billing portion. The billing portion that goes along with that is I may have patients that can't afford an $800 or $1,000 bill for plaque analysis, or I may have an insurance company that will not cover that, but I may want them to have plaque analysis. Let's say I have a shopkeeper, I have someone who works at a grocery store that I'm concerned about that, and I think they should have access to this type of technology just like the more wealthy or the more better off insured should. And so this is something you could process anyway. And now, are you going to make money at it? Are you going to make any profit? You're not going to make any profit because no one's going to pay for it. But you have that option available that you could run this analysis tool and just not bill for that. And so you wouldn't really get any profit out of it, but your patients can benefit from that. And so that's a way that you can open up this door for other patients to access this technology instead of giving them a $1,000 bill when they're just trying to make their rent for the month. For that. So I think that this concept of keeping this tool and this processing in-house, it's a very important one that I think is very ideal. As you saw earlier, the analysis for plaque is very quick. It's not, the turnaround time is within seconds. It's not a few hours, even 30 minutes or so. And so it really works well with your workflow and how we read CT as well. We already just spoke somewhat about the accuracy and the full control analysis. And then the third part the last part I want to harp on, one last thing is about reporting. And so one of the cardinal sins, at least in cardiology, is when you go back and you touch a record twice. If you have to go back in, report on a patient, close the report, more data comes in, you have to reopen the report, put an addendum in, and then close it again. You know, in the meantime, you're working on the rest of your patients, the rest of your scans. And so that I always find that very frustrating. I have to go back into a chart twice. It just slows down everything. And in addition, adding that addendum into a report, you don't make any extra money on that. You know, you touch the chart once, that's when you get a bill for that. And so you really don't want to do that. So if you can process a study, you have your report, you process it because you think it should be plaque analysis, you can put that data right into your report before you close it off that way as well. So I think there's a lot of advantages there to keeping this tool in-house and with the speed and everything like that. So I think with that, I'm going to conclude. Yeah, I'm just going to conclude my talks. We can have some time left for questions, but I appreciate your attention and attendance this morning. Thank you.
So we do have time for a couple of questions. I do want to thank all the speakers on their amazing presentations. I know they all spent a lot of time on it. Maybe just another round of applause for our presenters. So anybody with question, I would recommend them to go up to the mic, maybe introduce themselves, and then specify whether the question is directed towards the whole panel or a particular doctor here. No questions? There's got to be questions out there.
Yeah, I do have a question. Dave Nicholson with Ohio Health. Your plaque analysis platform, has it been compared, the quantification, to any other platforms, any other quantification process out there?
We have. I won't name any vendors. We have done extensive internal validations, both with manual readers as well with other quantification tools. And in both cases, we saw very high correlations, which is a good sign, I mean, for all parties, essentially. I think you'll find a lot of these plaque softwares is fairly high correlation between the quantitative results. So Yeah.
Published data or just in-house data?
it's in-house for now, yeah.
Okay.
The other question I'll have, maybe Kevin touched on kind of the economics of in-house versus send out. What percentage of patients going to benefit from plaque versus all the various other tools? Maybe you guys can comment. And how these send out models, oftentimes they're focused on a particular point solution, how a more comprehensive software can, aid in decision making, and how the different, quantitative value, how do you use that in daily clinical routine to help inform better decision making?
Yeah, I would say, well, again, getting back to using plaque analysis as a screening tool, unfortunately, you have to get a CCTA performed on the patient initially, and so to qualify for that and to even get billing for that, they often have to have symptoms of something, and so it's not really technically a screening tool at this time, and so I think that's the challenge is if I want to do a plaque analysis on someone, I have to justify get the CCTA with the contrast performed initially for that. And so it doesn't hit all the patients that I would like to. So I guess it depends on how your practice runs. But right now, probably like 10 to 20% of those CCTAs I'd have, you could go on to do some plaque analysis. The economics behind that, again, it can be challenging. I push the button if I want to send this or do plaque analysis, that someone's getting charged $1,000. Someone's either keeping that money or someone has to pay for that, and so that's always weighs on me too when I'm doing that analysis. And so keeping this in-house, again, it's not. I think I really like the concept of being able to perform this test really pro bono for patients that can't afford it. Then I don't feel guilty, saying, here's $1,000 and I'll tell you what your plaque volume is. If you pay me $1,000 or pay someone else $1,000 for that. And so I really like that concept too. And also for serial scans as well, I think that's another advantage that you have there. You have the same tool that you're using over and over again. This particular technology, again, is not dependent on billing. The company is not dependent on whether CMS reimburses $1,000. It could drop their reimbursement to $500 or $200 next year. And that doesn't impact the medical economics when it comes to this tool that you already have in-house as well.
So maybe I'll share just a slightly different perspective. So in our cardiometabolic program, one of the things that we've done a little bit different and novel is we actually do screening coronary CTs. Now, you're right, we have to be judicious about it, but it's really choosing that right subset of patient who comes with enough risk factors, but we know that any other screening tool, especially your younger middle-aged patient, is going to underestimate risk, right? So if you have a 40-year-old, 50-year-old severe family history of premature disease, is a calcium score of 0 sufficient? Are you going to stop your workup there? And to me, the answer is no. And that's where we use screening CTA. And so for those cases, I send all those patients for plaque analysis, and I find it to be tremendously helpful. But, if someone truly has a calcium score of 0 and they're in their 20s and 30s, yeah, maybe that's a little bit of an overkill. I think there's more of this to come, right? This is sort of uncharted territory. But I do think having it at their fingertips is very helpful.
Do you have any other questions? So we'll wrap it up here then. I appreciate everybody coming in. We love working with clinicians at Circle, whether it's on new publications, new methods, validations. Again, we got a very broad product portfolio, and we'd love to hear what you think. Please come visit us at our booth. I want to thank the presenters again for their presentations today. Thank you all.